Morning, everyone. Welcome to the International Brain Injury Association Special Interest Group on Disorder of Consciousness webinar, which is co-sponsored with European DOCMA project, which you'll hear more about shortly. Our webinar today is on recent findings on diagnosis, prognosis, and treatment of persons with disorders of consciousness, an update from the Disorders of Consciousness Special Interest Group and the European DOCMA project. We have a relatively tight schedule today with a group of wonderful speakers that have been assembled for this webinar. I'm going to briefly go through the topics and the speakers and then turn it over to Dr. Kike Noe to tell us about the DOCMA project. Our first speaker or set of speakers, Dr. Rita Formasano and Dr. Alfonso Magiacano, will be speaking on advances in diagnosis, nociception coma scale with personalized painful stimulation versus standard stimulus in non-communicative patients with disorders of consciousness and bedside strategies for improving diagnostic accuracy in prolonged disorders of consciousness. This will be followed by Dr. Ana Estraño on advances in prognosis towards an international consensus for bedside prognostication of prolonged disorders of consciousness. Dr. Aurora Thibault will be talking about advances in treatment should TDCS be implemented in rehabilitation to promote recovery in DOC patients, lessons from a multi-center translational trial. And then Dr. Caroline Schnakers will be speaking as part of a panel discussion where we will be taking questions, having open discussion, and talk about future directions for research. Just briefly, I wanted to share with you all that the Special Interest Group on Disorders of Consciousness, which is one of several subgroups now in the or under the umbrella of the International Brain Injury Association, has been quite productive. It's a wonderful group of international clinicians and researchers who meet pretty regularly and have worked on a number of projects over the last few years from which multiple publications have emanated. So I'm really pleased to co-chair the group with Dr. Schnakers. I think it's been a very productive group and hopefully will continue to be productive. I'm going to turn it over now to Dr. Noe to tell us a little bit about the DOCMA group and the work that's come out of that research. Kike.
Thank you, Nathan. I'm going to share my screen just to show you. Okay. Now you can see my screen. Yeah, I hope so. Okay. Hi, everyone. Welcome to this webinar. My name is Kike Noe, and I am the scientific coordinator of the DOCMA project. Just a few words about DOCMA for those of you who already don't know our project, and the next slide. Okay, I know how to move to the next slide.
Kike, hit the arrow button. That should take you to the next slide.
Yeah.
On your screen in the presentation mode.
In my presentation.
Yep. On your keyboard.
Yeah.
It should the arrow.
No.
The next arrow.
It's not working.
You could go out of presentation mode just into.
Okay. Yes, let me see. Okay. Okay, now you can see the slide. Yes.
Yes, yes,
Okay, let's do it that way.
yeah,
Okay, I like to think in DOCMA as a story of collaboration and leadership, and most of these stories, begin with a challenge to solve. And DOC represent a big challenge with, you can see the ethical and critical, legal, and socioeconomic implications, among others. And fortunately, there are a number of experts all around the world trying to find answers to these questions. And the great initiative of the IBI was creating an international network of experts, both clinicians, researchers, focused on the care of persons with disorders of consciousness. And thanks to this great initiative, we have learned that sharing our knowledge and working together as a team makes our actions more effective and more efficient and more rewarding. So with this aim, 4 years ago, 10 organizations, and including academic and non-academic facilities from 5 different European countries, you see in Germany and Belgium, Austria, and Italy and Spain, constituted this DOCMA consortium with the foundings of the European Union, and under this research and innovation staff exchange program, which is called RISE in the European Union program. And the peculiarity of this European Union program is that the founding comes related to staff exchanges or secondments that we call. But the exchanges and the complementary collaboration activities can be well designed and flexible enough to ensure the adequacy and the synergy within its own institution, program, and timeline. The RISE program, as I have told you, offers exchanges of staff members, researchers, clinicians at all career levels, okay? Not only experienced researchers, but only early researchers from international network of research, including academic, universities, and non-academic hospitals and facilities, to develop, and that's the main important point, collaborative projects and transfer of knowledge. The DOCMA approach is based on the development of training activities and the research exchanges among the partners around these 3 main challenges: diagnosis and assessment, data analysis and prognosis, and evidence-based treatments. And up to now, as you can see, more than 70 researchers have complemented almost 150 secondments, which is almost like 12 years of training, and have participated in an increasing number of conferences, workshops, and seminars, which is great for us. In terms of dissemination, this webinar, of course, is one of our dissemination activity, but DOCMA has also organized different symposiums, and our results have been presented in international meetings and published in international peer-reviewed journals. We are partners also of the Human Brain Projects and are proud to collaborate in international campaigns and in the scientific activity of some expert panels of prestigious scientific organizations like the European Academy of Neurology. And just to finish, as you probably know, DOCMA project is coming to its end in next January, but all of us, all the members of DOCMA and all of the members of the DOCSIP from the IBI are convinced that only through continuing in close collaboration will we make significant progress towards giving answers to the tremendous challenge that disorders of consciousness represent. And I want to take this opportunity to encourage you to join this group of colleagues and this group of friends, and to meet us in Dublin, next year. And just 2 things before proceeding with the scientific presentations. First, I want to thank you to the IBA, of course, for letting us to present our results here. And second, I want to give my special thanks to Margaret and from the IBA and to Roberto Llorens to make this webinar possible. So thank you.
Let's proceed with our first speaker, please.
Su? Oppure Vicky, esatto, no? Allora, posso avvicinarmi? Sì, sì, sì. Do you see my do you see my slides?
Yes.
Okay.
There we
Okay,
go.
my talk will focus on nociception comma scale with the personalized painful stimulation versus standard stimulus in patients, in a population of patients with disorder of consciousness. Let me start with the rationale of this study. As you know, persons with disorder of consciousness, such as vegetative state, recently named as unresponsive wakefulness syndrome, and minimally conscious state patients may perceive pain without being able to communicate their discomfort. I would like to show you this short video where you will see some mimic reactions which resemble pain or sufferance, pain perception or sufferance, but in a stereotyped and repetitive way. No, not this one, sorry, I have to go back to the previous video. This is the first one. Silvia is in minimally conscious state minus. And you see that the mimic reactions were continuous, stereotyped and repetitive. But after 1 month, Silvia regained the ability to interact with the environment. And as you will see in this video, she will show again these mimic reactions like sufferance only when the speech therapist touches her upper limb, right upper limb. Sorry, this is the video I would like to show you. And this is what I told you before.
Volevo fare ciao con la mano. Dai. Con le dita. Fai vedere un po'. Poi ci tengo questi video. Ti saluti un po'. Male.
Only to show you that the differential diagnosis between spastic crying and sufferance or pain perception may be a huge challenge. So as you all know, probably nociception comma scale and its revised form have been proposed to assess nociception in patients with disorder of consciousness. This is the original scale proposed by Caroline Schnackers with the different sub-items: motor response, verbal response, visual response, and facial expression. But 2 years later, Camille Châtel showed us that also without the visual sub-item, the efficacy of the scale and the efficiency of the scale did not change. The aim of this first monocentric study was to compare the standard painful stimulus with the standard pressure on fingernail bed versus personalized painful stimuli, as indicated by the neuro rehabilitation team and the caregivers. So we enrolled 21 patients with disorder of consciousness, and responsiveness and pain perception were assessed respectively with the COMA recovery scale revised, that you know is the gold standard of the behavioral assessment of patients with disorder of consciousness, and with nociception COMA scale revised, either with the standard stimulus and personalized stimulus. So we were able to show that 42.8% of the patients had the higher scores in response to personalized stimulus compared to the standard one. These are the main maneuvers which were able to provoke pain. You see hand opening or hand mobilization or head mobilization, for example. And these are the etiologies of the patients enrolled. As you see here, in around 62% of the patients, a personalized stimulus could be identified, which was around 43% of the entire group. And the black bars here show you the different sub-items of the nociception COMA scale revised either with the standard stimulus and the personalized one. And this is the nice correlation between the COMA recovery scale revised and the nociception COMA scale, both stimulus, either with the standard stimulus and personalized stimulus. So our preliminary results show that a larger number of non-communicative patients with DOC showed higher scores with the personalized stimulus in comparison with the standard stimulus. And this is the first publication on neuropsychological rehabilitation, and this is a review that together with Professor Zassler, with Nathan Zassler, we tried to summarize all the issues of pain perception in patients with disorder of consciousness. And we also submitted a letter to brain injury in order to suggest to use some paraclinical tests and also the involvement of the caregiver to reveal covert cognition, at least during discontinuation of artificial nutrition and hydration. So this is the multi-center, international multi-center study ongoing, where we, with the preliminary results that we submitted to the Dublin Congress, the International 14th World Congress on Brain Injury. And these are all the participants from the different participating centers. So let me conclude with some ethical consideration, because the neurobehavioral and clinical legal aspects of the assessment and treatment of persons with DOC have not evolved in parallel with our advances in the use of diagnostic innovative techniques, either neurophysiological and neuroimaging techniques, as well as a specific pain treatment. So the families and caregivers, in fact, indeed, are often worried about the possibility that their loved one is in pain or suffering, and yet we as clinicians cannot provide definitive answers in response to these concerns. So in conclusion, a multimodal assessment that includes an appropriately focused bedside neurological, neurobehavioral examination, as well as advanced neurophysiological neuroimaging testing, should be advocated for to enhance our ability to opine on patients' pain perception capacities, improve the differential diagnosis of the specific disorder of consciousness situation, and guide patient-specific management, as well as family psychoeducation and support. Thank you for your kind attention.
Hi, my name is Alfonso Magliacano, and today the title of my presentation is Bedside Strategies for Improving Diagnostic Accuracy in Prolonged Disorders of Consciousness. And then I'm going to present two studies for which the collaboration with DOCMA partners was very important. Prolonged disorders of consciousness include the condition of unresponsive wakefulness syndrome, in which patients exhibit no sign of awareness, but show a recovery of vigilance compared to coma, and minimally conscious state, in which minimal voluntary behavioral responses can be observed. Patients in MCS seem to retain residual cognitive activity and show a better outcome than patients in UWS. So accurately distinguishing between patients in UWS and patients in MCS is of real importance for assisting physicians and caregivers on decisions about patients' management. So to date, differential diagnosis of DOC relies on clinical observation of patients' behaviors in response to multisensory stimulation. But behavioral responses could be affected by fluctuation in patients' level of vigilance and by possible concurrence of sensorimotor and cognitive impairments. And these complications could lead to a rate of misdiagnosis up to 40%. Standardized clinical scales and sophisticated neuroimaging techniques and electrophysiological techniques have been developed in order to reduce such a diagnostic ambiguity. But these instruments are not free of limitations. For instance, notwithstanding the coma recovery scale revised is the most accurate clinical scale for distinguishing UWS from MCS. An agreement regarding the stimuli to be provided during the assessment has not been reached yet. And indeed, some experimental studies showed promising results using salient material with emotional and self-referential value, but this suggestion has not been systematically applied in clinical settings. And similarly, neuroimaging and neurophysiology have a low sensitivity at single subject level. And paradigms involving high-density EEG, PET, or fMRI are also expensive and time-demanding. So for these reasons, we implemented two studies aimed at better clarifying the main issues of the diagnostic assessment of patients with DOC. In the first study aimed at investigating through a systematic review of the literature the actual effectiveness of emotional salient compared to neutral stimuli in eliciting volitional responses. So this study originated from the observation that the level of responsiveness measured by a formalized assessment sometimes conflict with opinions held by patients' relatives that report more and more complex responses than clinicians. Several studies argue that this difference might be ascribed to characteristics of the stimuli provided to patients. However, the effectiveness of salient material in boosting patients' responses with respect to neutral material was not systematically investigated. So an online search was performed on original studies involving patients in UWS and MCS that compared salient versus neutral material for diagnostic purposes. And after an article screening, the quality of evidence for each included studies was rated by 2 independent judges through the grade system. 10 unique articles met the selection criteria and were included in the systematic review. The overall quality of the evidence for the included studies was judged to be low. The included studies found that a mirror is more effective than a neutral object and than a moving person in eliciting a patient's visual pursuit or visual fixation. A similar attentional facilitation toward the patient's own face and familiar faces when compared to unfamiliar faces could be also observed in two eye tracking studies. An advantage toward the patient's own name and familiar voices compared to unfamiliar voices or neutral sounds was also reported. But such evidence were not completely confirmed by neurophysiological studies. So in general, studies on the use of emotional and self-referential stimuli suggested that presenting own or familiar faces, own name or familiar voices could foster behavioral and electrophysiological responses in patients with disorders of consciousness. But the limited number and the low quality of the evidence make it difficult to provide reliable recommendations. So for this reason, in this study, in the next study, we used a different approach to identify a reliable diagnostic marker independent from intentional behavioral responses and easy to collect in clinical practice. We focused on spontaneous eye blink rate as a possible measure associated with the patient's level of consciousness. The rationale for investigating spontaneous eye blinking in disorders of consciousness is that it has been shown that eye blink rate is an index of cognitive load in healthy individuals. And this relation is thought to be mediated by dopaminergic activity. A mesocircuit hypothesis suggests that dopaminergic projection within the striato-thalamocortical circuits play also a key role in regulating conscious processes. And this is confirmed by evidence that a relative sparing of thalamocortical neuronal assemblies has been reported in patients in MCS compared to patients in UWS. So a sample of patients with disorders of consciousness in which the eye blink rate was collected at rest was enrolled. A subgroup of patients who presented any auditory response to the coma recovery scale revised was assessed on an auditory audible paradigm to search for changes in eye blink rate as a function of cognitive load. And according to a within subject design, each patient attended 2 experimental sessions. In all patients, the eye blink rate was collected during a 3-minute rest condition in each recording sessions via an EEG. And in the selected subgroup, after the rest condition, the patients performed a passive audible task in the first session and an active audible task in the second session, followed by another rest phase of 3 minutes. A convenient sample of 24 patients with prolonged disorders of consciousness was enrolled, including 11 in UWS and 13 in MCS. And of these, 11 patients complete the paradigm, including the audible task. The analysis on eye blink rate at rest showed a significant effect of the clinical diagnosis, as eye blink rate was higher in MCS than in UWS in both sessions. The eye blink rate at rest also correlated significantly with an index derived from the coma recovery scale revised. For patients who completed the audible paradigm, however, the analysis showed that the eye blink rate was not affected by cognitive load for both UWS and MCS. So in the study, a clear difference in eye blink rate was observed between diagnostic groups due to a higher eye blink rate in MCS with respect to UWS. The higher eye blink rate in MCS might be interpreted as an index of their spared cortical subcortical dopaminergic projections and over their greater tendency to visually explore the environment. But in a subgroup of patients, the experimental manipulation of the task cognitive load did not exert any effect on patients' eye blink rate, irrespective of the clinical diagnosis. So these findings represent the first evidence that the eye blink rate collected at rest might constitute a simple diagnostic biomarker for prolonged disorders of consciousness, easily collected at bedside and contributing to the clinical distinction between UWS and MCS, thus helping to reduce the rate of misdiagnosis in DOC patients without the need for additional high-tech methods. So in summary, with these works, it has been suggested that using a mirror and the patient's own name in the assessment of visual fixation and auditory localization induces a larger number of appropriate responses. However, to date, the usage of this kind of stimuli is only partly included in standardized clinical assessments, and further evidence for their effectiveness are needed. Moreover, it has been provided evidence that recording patients' eye blink rate at rest could accurately differentiate UWS from MCS. And if these findings will be confirmed on larger samples, eye blink rate should be introduced in standard diagnostic protocols of patients with disorders of consciousness. And we thus hope that the evidence collected here should be transferred into future clinical practice. At the end, I would like to thank you for the attention and also all the DOCMA partners for their scientific and emotional support, without which this project would never have been completed. Thank you.
Okay, can we have our next speaker, please? Anna?
Okay, can you see my screen? Okay, thank you.
Yes, you're all
I'm
set.
Anna Estrana. The second topic that the DOCMA consortium addressed in a specific work package, the work package 2, was to define evidence-based recommendations on the prognosis of disorder of consciousness patients. And as a part of this work package called Diagnosis, Assessment Techniques and Data Collection for a Better Characterization and Prognosis of DOC Patients, the DOCMA Consortium launched and developed an international longitudinal study in collaboration with the IBIA Special Interest Group on Disorder of Consciousness. Today, I'll present the results that have already been published. Why our interest in such a topic? The prognosis is one of the challenges that clinicians who work with the patients with disorder consciousness face every day in clinical practice. First of all, clinicians are routinely called upon to provide to patient family reliable prognostic information for guiding decision-making and planning a more appropriate care pathway in terms of intensity and duration of treatment. Moreover, it would be very important to identify patients with the high probability of late improvement in order to allocate and better optimize the healthcare resources necessary for the long-term management of such complex patients. Unfortunately, when we talk about the prognosis of patients with the prolonged disorder of consciousness, we talk to date in a climate of uncertainty, since nowadays a relatively small number of studies on prognosis, marked here in red, has been published with respect to paper on treatment and diagnosis. And most of these studies has been published only in the last 10 years, reported in the last All-American Academy of Neurology guidelines. Indeed, to date, the clinical evolution of disorder of consciousness has not been completely comprehended yet, as only recently, based on recent observation of a possible rare but not exceptional late recovery of consciousness, the American Academy guidelines recommended using the more appropriate term of prolonged instead of old term persistent when these clinical conditions persist more than 28 days after injury, and the term chronic to identify patients after the 1994 classical time limits instead of the old term permanent that is closely tied to the reversibility of this clinical condition. Indeed, when discussing prognosis, physicians should consider that late improvement of cognitive and functional motor impairment is still possible even in anoxic patients, especially younger ones, as you can see in these young anoxic patients who recovered full consciousness and even assisted walking long time post-injury. Another factor that can make it difficult to comprehend the natural clinical evolution is the early withdrawal of life support treatment. For example, this recent longitudinal study on a large cohort of cardiac arrest survivors showed that for about 20% of patients who died because of early withdrawal of life support, a good outcome could be predicted on the basis of available prognostic information. This critical point raises important questions about the need for solid predictive factors, especially in considering that most often the withdrawal of life support in the acute phase or the discontinuation of intensive long-term management of such patients are applied on the basis of non-robust predictors, or may be influenced by patients' family preference, or sometimes may be driven by the perception of the treating clinical team that the prognosis is poor. And what we know about prognostic indices? We know that absence of N20 cortical component on somatosensory evoked potential is a robust predictor of poor outcome in anoxic comatose patients, as recommended by the European Society of Intensive Care. But the same neurophysiological predictor can be also applied to anoxic prolonged disorder of consciousness patients, as recommended by American Academy of Neurology guidelines on disorder of consciousness patients. However, the presence of an N20 cortical component do not identify patients with the same probability of a conscious and motor recovery, as you can see in these 4 anoxic patients where N20 cortical component was recorded, but their clinical outcomes were significantly different. So we should search also for markers that could predict a good outcome. Last, prognostic information for MCS patients and for patients who will experience late recovery are still lacking. So to date, several issues on prognosis remain open. And maybe because of these several issues, the prognostic procedures markedly vary across countries, both in adult and pediatric population with the disorder of consciousness, as we found in these 2 recent IBIA international surveys. Based on these critical issues on the prognostication, the IBIA and DOCMA consortium launched a multicenter international longitudinal study for better characterizing patients with the high probability of recovery for short, 6 months, long, 12 months, and very long-term outcome in order to provide scientific evidence for an international consensus on prognosis. In this project, 12 medical centers located in Asia, Europe, and America participated to this project. The majority of them were IBIA members, and 5 of them were also involved in the European DOCMA project. We enrolled 147 patients with the prolonged disorder of consciousness, 71 in vegetative state, 76 in minimal conscious state. 143 of them were followed until 24 months after injury. At study entry, we collect demographic information, but also information from medical history, patient's clinical condition, that is a level of consciousness measured by the coma recovery scale revised, level of functional disability assessed by the disability scale, and the clinical diagnosis. And we also recorded neurophysiological exams, easy to record at the bedside, standard EEG, somatosensory evoked potential, and event-related potential elicited by auditory audible paradigm. Before starting the patient's enrollment, all participating centers shared the protocol for EEG recording and analysis. For instance, the visual analysis of EEG was performed using a recent categorization of EEG, which proved useful in distinguishing patients in MCS from those in VS, as for instance, presence of low voltage pattern EEG or lack of EEG reactivity was associated with high sensitivity to patients in VS with respect to patients in MCS minus MCS plus. Also, we shared the protocol of record and recognizing N20 cortical component on somatosensory evoked potential and P300 cortical component on event-related potential elicited by auditory audible paradigm. What we found? We found that the overall clinical evolution was worse in patients in VS than in patients in MCS, since a high number of VS patients died or did not improve their clinical status at short, long, very long-term outcome, likely due to low severity of brain damage in VS patients, and maybe to better response to the treatment that has been found in MCS patients. Also, as you can see here in this cohort of patients, we had also late recovery of full consciousness in both diagnostic groups with lower percentage in VS patients. Mortality rate was higher in the first year after brain injury than in the second year after brain injury in both diagnostic groups, likely because of high clinical instability, a higher risk to develop severe medical complications in the first year post-injury. And the mortality rate was higher in vegetative state than in minimally conscious state. About predictors of both minimal and full recovery of consciousness at 6 months post-injury, we found that lower age, shorter time post-injury, higher level of responsiveness, consciousness measured by coma recovery scale revised total score, and presence of EEG eye-opening reactivity predict better outcome at 6 months. And the same markers, along with the male gender, may predict long-term recovery of consciousness at 24 months post-injury. About the predictors for the mortality, the Cox regression analysis on 135 patients in whom all data were collected provided a significant final model in which only older age and female sex were significantly associated with a high risk of mortality. But these two predictors of mortality did not apply to the same extent in the two diagnostic groups. Indeed, in vegetative state, older age and lower level of responsiveness as measured by coma recovery scale revised total score were significantly associated with a high risk of mortality, whereas in MCS group, female sex and absence of alpha rhythm on EEG were significantly associated with a high risk of mortality. Until now, I presented the already published result, but more recently, we started with a new analysis using a machine learning approach. Why? Actually, recently, in another cohort of patients with prolonged disorder of consciousness, we previously identified a consciousness domain index based on the combination of CRSR subscores in the single patients using a machine learning approach. This index, consciousness domain index, classifies a whole sample of DOC patients in two main clusters, regardless their clinical diagnosis, age, etiology, and time post-injury. As you can see in this radar chart, where the visual and motor subscales are the most influencing factors. We also found that this index, the consciousness domain index, can predict consciousness recovery at 6 months post-injury. And this predictive value is higher than that of a clinical diagnosis. So we decided to apply this machine learning approach to our IBIA DOCMA sample in order to externally validate the prognostic accuracy of this index with respect to the clinical diagnosis at admission, and also with respect to common recovery scale revised total score at admission that we already identified as a robust predictor of consciousness recovery. And also we would like to validate this predictor, this index, for consciousness recovery at 12 and 24 months outcome. We found that also in our cohort of patients, IBA DOCMA cohort of patients, this consciousness domain index showed a prediction accuracy 5% higher than clinical diagnosis at admission, but also then higher than common recovery scale revised total score equal to 8 or 10, that is the cutoff that can distinguish, better distinguish patients in MCS from those in MVS at 6, 12 and 24 months after injury. This finding has been confirmed by the regression analysis too, in which the models at 6, 12 and 24 months, including the CDI, this index, had a higher predictive value than the models including clinical diagnosis and CRS total score. By this algorithm, which will be available in a short time, this is the link you can see here, any physicians will be able to enter the CRS-R scores of a single patients. So the algorithm automatically classifies the patients in one of these two clusters of CDI, as you can see in this example, where the patient is classified as a CDI 0 with the confidence level 70%. This classification of CDI within a multimodal assessment will help the clinician to make a more solid prediction of recovery of consciousness. Most likely, our study showed several limitations. For example, we did not consider possible factors that could influence clinical evolution, such as medical complications that may have a negative impact on clinical evolution, mortality, and on clinical improvement too. Or we did not consider the rehabilitative treatment, which may facilitate recovery of consciousness and functional abilities. As you can see in this large cohort of patients with a prolonged disorder of consciousness of traumatic etiology. But despite these limitations, we hope that our IBIA DOCMA project will provide scientific evidence for an international consensus on the prognosis of prolonged disorder of consciousness. Which evidence? We confirmed that patients in VS and with non-traumatic etiology have a worse outcome than patients in MCS and with traumatic etiology in terms of survival and clinical improvement. We found that mortality and consciousness recovery are higher in the first year. And last, we confirmed that late recovery of consciousness is possible in all diagnostic and etiological groups. Finally, we confirmed that only a feasible multimodal assessment combining clinical and neurophysiological evaluation such as EEG and event-related potential in somatosensory evoked potential can provide solid prognostic information to help clinicians in the long-term prediction of mortality and recovery consciousness. We hope this international study can stimulate the standardization of prognostic procedures for patients with the prolonged disorder of consciousness. First of all, because we have, with this project, European project, we have demonstrated that it is possible to make prognostic procedures homogeneous across different settings and different countries by sharing the same protocols. And I would like to point out this aspect, this important aspect. This goal can be achieved especially if we use promising prognostic markers, clinical and neurophysiological markers that are easy to record at a patient's bedside and to analyze in all patients. I think this is the main value of our DOCMA IBA project. I thank all of you for your attention, but above all, I would like to thank all the co-authors, Kike, Caroline, Rita, and my collaborators, Alfonso, without whom this international project would not have been possible. Thank you.
Hello, everyone. Thank you very much for the first talks. So I'm gonna share my screen. Oops, here it is. All right. Can you all see my screen? Great, thank you. So yeah, first let me say how I'm glad to have the opportunity to present the result of this multi-center study on transcranial direct current stimulation for patients with disorder of consciousness. So this work is the result of more than 5 years of effort and collaboration between 10 centers in Europe, and it was conducted as part of the IBIA DOCSIG as well as the DOCMA projects. And the question we aimed to answer with this study is whether TDCS should be implemented in rehabilitation for patients with disorder of consciousness. So as you know, patients with disorder of consciousness, they, by definition, they cannot communicate, meaning that they cannot actively participate to rehabilitation program. And in addition, they suffer from severe motor disabilities, fatigability, and other disorders. And that's why they cannot really take part to active rehabilitation strategies. And so we need to find alternatives for really trying to cure and help those patients improve. And so recently, as part of the COMA curing campaign initiated by the Neurocritical Care Society, we wrote a gap analysis paper on treatment for patients with disorder of consciousness. And so to do so, we reviewed the literature and we categorized the treatments, the therapies into 5 categories. So the first is the pharmacological trial. Then we have electromagnetic, such as TDCS or TMS. We also have mechanical interventions, such as ultrasound therapies, or sensory stimulation, such as music, for instance, as well as regenerative approaches. And so we assess the level of evidence, the efficacy, the safety, the limits, and the ongoing trials for these 5 categories of therapies. And so far, the most studied intervention is non-invasive brain stimulation, and specifically TDCS, or transcranial direct current stimulation. And we also have 10 ongoing randomized controlled trials that we identified in clinicaltrial.gov. So this gap analysis paper it identified a few gaps. The first one is that we really need to better understand the mechanisms of these therapies. We also need large randomized controlled trials, and we also need biomarkers to measure subclinical therapeutic effects, especially in the early phase trials. So we concluded that we need to develop a precision medicine approach in which clinical trial enroll patients based on their physiological receptivity to specific therapies. And we need absolutely to conduct multi-center trials to obtain sufficient statistical power. And so, as I just said, we really need to better understand the mechanisms of both the action of the therapies, but also the mechanisms of recovery of consciousness. And the main hypothesis that explains both the loss of consciousness of patients with disorder of consciousness, as well as the recovery of consciousness following therapeutic intervention, is a mesocircuit model developed by Schiff and exposed the first time in 2010. And this is what you can see on this figure. And so in very brief, it says, the model says that like in an healthy brain, the striatum usually disinhibits the thalamus, the globus pallidus interna, sorry, which normally inhibits the thalamus, and so you have this this normal thalamocortical connectivity. However, following a severe brain injuries resulting in a disorder of consciousness, we see a marked differentiation of connection from the central thalamus and striatal and cortical targets, which in very short will affect the cortico-striatal connectivity. And due to this lack of excitation of the striatum, we will see a reduced inhibition of the globus pallidus interna, and thus this globus pallidus interna will inhibits the thalamus, and thus this will reduce the thalamocortical connectivity and really have a reduced of cortical activity in patients with disorder of consciousness. And interestingly, so far, most of the therapeutic approaches that have been tested in disorder of consciousness target specific brain areas that are part of this mesocircuit, such as the striatum, the globus pallidus interna, or like the frontal cortex. So there are a few drugs that have been tested, such as amantadine, apomorphine, and zolpidem, as well as a few trials using non-invasive brain stimulation, such as transcranial direct current stimulation and repeated transcranial magnetic stimulation. We also have this, on top of this top-down approach targeting the cortex, such as TDCS and RTMS. There are also like more like bottom-up approaches, such as transauricular or invasive vagus nerve stimulation, trying to stimulate the brain more in a bottom-up manner, as well as deep brain stimulation and ultrasound, which will directly target the thalamus, still trying to stimulate this thalamocortical connectivity. And so here in the, and this is mainly the main topic of my research, so we will focus on transcranial direct current stimulation. So what is TDCS? So TDCS is a very simple technique. It's really user-friendly, it's safe. And so it uses the same principle as a galvanic current or iontophoresis. So it uses two electrodes, one anode, which is the positive, and one cathode, the negative. And the current goes from the anode to the cathode, and it stimulates the areas that are between these two electrodes. So the anode will increase membrane depolarization and therefore increase neural excitability, and the cathode will do pretty much the contrary. So beside the direct or online effects, TDCS can modulate neural plasticity and induce long-term changes. So those long-term changes are not yet fully understood, but they are thought to be linked to sodium or calcium ion channels opening or modification in conductance, and a modulation of NMDA receptors excitability as well. So on these two figures, you can see the main two brain regions that are usually targeted with TDCS, so the prefrontal cortex, mainly to promote cognitive function, and the motor cortex for motor function, obviously. So what has been done so far in the field of disorder of consciousness? So here it's a figure showing the main brain areas that have been targeted using TDCS in patients with disorder of consciousness. So the main one is the frontal cortex, which shows kind of a promising result in a small sample randomized control trial. We also tried to targeted the precuneus, which is also a hotspot for consciousness and consciousness recovery, but the effects were quite moderate. So the results were quite mixed. We also tried to improve motor function to help the patients to express their sign of consciousness, but the two trials, I have to say that they were the sample size were quite small, but we really did not find any improvement in sign of consciousness when we targeted the motor cortex. And finally, we also tried to target the external awareness network, trying to stimulate these frontoparietal areas and network using multi-channel stimulation device as part of the Luminous project. And again, here we did not find any significant improvement following the stimulation of this frontoparietal cortex at the behavioral level at least. So what can we say from those clinical trials that have been conducted? Well, at the group level, at least, it really seems that the prefrontal area is the best area to target. However, we really need multi-center trials. And so why do we think that the prefrontal area is the best area to target? Well, this is completely in line with the major circuit model. As you can see here, there is a privileged interaction connectivity between the frontal area and the striatum, which might increase the activity of the striatum, which can in turn inhibit the globus pallidus interna and making sure that the thalamus can be connected with the rest of the cortex. But this is still only an hypothesis, and this should be better investigated. So then to really answer the main objective and the main gap that were identified in various reviews, we decided to conduct this multi-center study as part of the IBIA DOCSIC and the DOCMA project. And so we really took the advantages of this beautiful consortium to run this multi-centric study. And you can see the centers that were involved all over Europe in this effort. So the main objectives were the following: is prefrontal TDCS more effective than sham in improving consciousness in patients with disorder of consciousness while being in rehabilitation? Is there a difference between traumatic and non-traumatic etiologies and between unresponsive and minimally conscious patients? And finally, we aim to look at if the effect could last over time. And so we assessed the patients up to 3 months after the end of the stimulation sessions. And so here is the protocol. So the patients were in rehabilitation. They were stratified based on the diagnosis and their etiology. They received 20 minutes of TDCS per day, 5 days per week for 5 weeks. And we, of course, targeted the prefrontal cortex. The intensity was 2 milliampere. And the patients were either allocated to the active group or the sham group, which was exactly the same, except that the stimulation was turned off after 30 seconds, but the devices used allowed to be fully blind. The researcher was fully blinded of the allocation. As I said, we stimulated the patients once a day, 5 days per week for 4 weeks. So we had 20 sessions of stimulation. And then we used the Coma-Recovery scale to assess the effect before and then once a week. And then, as I said, up to 3 months follow-up to evaluate if the effect could last over time. And so here is our results. So we had 10 centers who enrolled patients. So at first, our analysis determined that we should have enrolled 124 patients, but we plan to run interim analysis after half of the patients would be enrolled. And so we conduct interim analysis after 62 patients who completed the study. But unfortunately, we had to stop the trial for futility. So indeed, when we run this power calculation, we should have enrolled hundreds of patients to achieve the appropriate power. So that's why we stopped the trial for futility. So here we enrolled 62 patients. The mean age was 44 years old, 37 weeks post-injury. Most of the patients were male. Half of them were in minimally conscious state. A slight majority of non-traumatic etiologies, and 33 received active stimulation. On the right, you can see the flow charts. So here, as planned, after 4 weeks of stimulation, there is about a 20% of dropout, which seems high, but you know that the patient with disorder of consciousness, they are highly fragile, so this was expected. However, at follow-up, we have more than 50% of the patients who dropped out. So the first reassuring result is that we did not observe any TDCS-related severe side effects. So TDCS applied in disorder rehabilitation is safe. And then, so as planned, we used the generalized linear mixed model to look at the effect of time on the evolution of the coma recovery scale revised total score. And the difference between the treatments and the sham group. So this is what you can see on these graphs. So the dashed line is represent the coma recovery scale total score of the active group, and the full line, the black line, is the sham group. And here it's the evolution of the coma recovery scale during the 4 weeks of stimulation. I mean, not surprisingly, based on the interim analysis, we did not observe any effects of TDCS during the treatment period. Then we looked also at the evolution of the coma recovery scale total score during the follow-up period, which you can see here. Again, the difference between the active and the sham group. For the active group, we can see kind of a slight improvement. However, this was not statistically significant, so no effect here. So what did we do next? So then we run like exploratory analysis, trying to better understand the results and if a subgroup of patients could still show some improvement following TDCS. So this is what you can see on this graph. Here you see the difference between
Ja, dat was echt verschrikkelijk. En die zei ook, ziekte, 12 maanden, 12 maanden.
Please
Maybe you
mute
can
yourself.
Okay, great. So here, what you can see is the difference between baseline and the 4 weeks of stimulation. So the coma recovery scale total score post-stimulation minus baseline for the sham group in white and the active group in gray. And here it's for every subgroup, so unresponsive patients, minimally conscious patients, and then non-traumatic patients and traumatic patients. I'm sorry, the phone in my office is ringing. It will stop soon. And I cannot reach it from here. And so we did this subgroup analysis for after the 4 weeks of stimulation, and then after the follow-up period, so at 3 months follow-up. And so what did we observe? So we did not find any difference for these subgroups during the 4 weeks of stimulation, but we did find an improvement, a significant improvement for the active group compared to the sham group, for the subgroup of patients in minimally conscious state, and for the subgroup of patients in traumatic, from traumatic brain injury, which is not that surprising because we know, and Anna just mentioned it before, that this subgroup of patients have a better prognosis compared to unresponsive or patients from non-traumatic etiologies such as anoxia. And here, what is also interesting is that we did not find an effect during the stimulation period, but we did find a delayed improvements. And so the reason why we might observe a delayed effect might be due to the impaired brain plasticity mechanisms in patients with disorder of consciousness, as compared to what is observed in LC control. And therefore, TDCS, the related neuroplastic mechanisms may occur also in a delayed manner. And this phenomenon was observed in other populations of patients as well, that the TDCS have kind of a delayed effect. So to conclude, following this result, we can say that at the group level during rehabilitation, TDCS of the prefrontal cortex does not improve the recovery of patients with disorder of consciousness. Thus, we could ask ourselves the question whether rehabilitation is the best period to apply TDCS in disorder of consciousness. And we might say that as patients are already highly stimulated with physical therapy, occupational therapy, and so on, the effect of TDCS might be kind of occulted. And that's why maybe also the improvement is also seen after 3 months follow-up. Or maybe that adding TDCS during rehabilitation while patients are already overstimulated might be deleterious. So we think that maybe that's why in the previous randomized control trial that really targeted more like chronic patients at home or in nursing home, when I will really stop this phone. I'm really very sorry for that.
It happens.
Yes. This person is kind of insisting to reach us, but anyway. Oops, just turn it off. So yeah, so I was saying that yeah, maybe rehabilitation is not the best time to apply TDCS, and the previous randomized control trial targeted chronic patients at home or in nursing home where the patients are less stimulated, and so it might be easier to recapture the effect of the TDCS. But this also shows that the effect side of TDCS in patients with disorder of consciousness is quite moderate. However, we can say that for patients in minimally conscious state and from traumatic brain injury, there is a better recovery at 3 months follow-up. So to answer the first question, whether we should use TDCS in rehabilitation, I would say yes for patients in minimally conscious state and patients from traumatic brain injury, as TDCS is really easy to apply and safe. So I think that for those patients, we should use TDCS. And very briefly, as we know that the effect of TDCS are quite moderate, what can we do? We should try really to optimize the effect, for instance, by really targeting the moment of the stimulation. And here, this is a study that is ongoing using a closed-loop system that launch the stimulations based on the patient's level of arousal. An alternative would also be to use the patient's structural lesion to really adapt the montage in order to really avoid the lesion and make sure that the currents really reach the target area. And so we'll really use individualized montages. And finally, I also think that we should really combine different therapies using top-down versus bottom-up approaches, testing, for instance, alternating current stimulation or the combination of transauricular vagus stimulation with pharmacological therapies as well. So there is still a lot of work to do. And but I'm sure that thanks to this kind of initiative, the IBIA DOCSIG and the DOCMA project and the wonderful people who are extremely invested, we come closer to the goal of curing coma. So we come closer every day. So I would like to, of course, thank all of my colleagues at the Coma Science Group. As you can see here on this picture, all these young talented researchers. I'm also really delighted to work with all those people who are involved in this multi-center study. Their names are listed here. And of course, I would like to thank you very much for your attention. And I'm really sorry for the technical problem. Thank you very much. I will stop sharing my.
Thank you very much, Aurore. I have been gathering some questions. I think that I will just try to follow kind of a chronological order, starting with Rita. Rita, are you there?
Yes, I'm here. Yes, I'm here.
So a question regarding the protocol that you put in place. Have you thought about developing maybe a questionnaire or a tool that clinician could actually use for determining what area is painful? Do you think that that's something that based on the study you did, you could do?
Yes, this is a very interesting question because up to now we simply asked the physical therapist, occupational therapists, and the caregivers. So especially the main caregivers. So I mean the people who every day is close to the patient. If they have the feeling that the patient is sometimes suffering or whether the patient perceives pain, and which maneuvers they noticed could provoke pain in that specific patient. So we could try at the end of our multi-center study to standardize all the maneuvers which were reported by the clinical staff and the caregivers, and try to offer some suggestions to the neurorehabilitation team and also the caregivers who care for their loved ones at home. So this is a very interesting idea.
I think that would be a great follow-up project actually for the DOCSIG if you're interested in involving the group in that project. It would be great. So more question now I had another question actually. So for the Blink, the presentation, Alfonso, your presentation. So there was quite a bit of question. I think people were a bit surprised, including me. Then Blink has, you know, that kind of interesting diagnostic value, since it's really, you see it rather as a reflex. So that's a very interesting point that you make. I think people were interested in knowing if you saw any EEG change in the Blink that were elicited by the patient through the oddball, if I understand correctly. But I think
yes,
question regarding that, just
yes,
making sure that people understand.
Yes, we performed an audible paradigm, and we concurrently to the eye blink rate, we measured the P300 on the audible paradigm, but unfortunately we did not find any change in amplitude or latency of the P300 between the active and the passive task. So we cannot, the changes in blink rate was not related to a change in electrophysiological measures. So we interpreted these results in the sense that our patients could not direct attention to the stimuli.
Mm-hmm.
And
was there any power spectrum analysis done just to look at the change maybe after the blink, if there was any increase in alpha or any change in ratio, fast frequency, lower frequency band waves?
Okay, we did not perform this analysis, but I believe that this is a nice suggestion for a future study.
And also, it's a bit in parallel, I have to say, to the core of research of Lionel Nakash, who was interested in habituation in auditory startle and published a paper about that, showing that actually it might be a sign of consciousness, even though everyone is seeing it as a reflex. It might actually be habituation, might be actually be associated to an integrity of the frontoparietal network involving the prefrontal and mesiofrontal that is recovering in patient MCS, for example. So that's very interesting. I think that
Caroline, sorry, probably I didn't specify that there was one of my questions to Alfonso, but I didn't specify to whom was the question. I don't know if I can ask Alfonso directly.
Go for it.
Yeah, because I asked you whether you checked also the blink reflex habituation, because as you know, in Parkinsonian syndrome, for example, there is a clinical sign which is an indistinguishable nasoglabellar tap test. And we published many years ago that in some post-traumatic Parkinsonian patients, there was a blink reflex habituation change, which was correlated with diffuse axonal injury. If you are interested in, I could send that old paper to you, because I think that what is you should check also if the patient have Parkinsonian symptoms, because you know that some of our patients may have akinetic mutism and they have a rare blinking, not because they are not aware or not in contact with the environment, but because they have a post-traumatic Parkinsonism, for example, or a post-hypoxic Parkinsonism. So I think that you should also check the extrapyramidal signs associated with the blink reflex habituation.
This is, I think that this is another important issues to investigate. But in our study, we just focused on spontaneous blinking, and we neglected the blinking reflex or the voluntary blinking. So we just assessed the spontaneous eye blink rate.
Regarding the blink, there was also a question about if the blink rate changes, the patient emerge, and is there a threshold that differentiate VS and MCS patients?
So we did not follow these patients up to their emergence, but it's one of our aim. So we want to perform another study for identifying, for investigating if the eye blink rate is also a prognostic index more than diagnostic. And for about the cutoff, we could not identify a precise cutoff, but I can tell you that the mean eye blink rate of the patients in UWS was about 7 or 8 blink per minute, whereas the average for minimally conscious state patients was 15 or 20 or above blinks per minute. So it was a very clear difference.
Okay. Thank you very much. It was very interesting. Anna, just wanted to, probably people are interested, again, come back with that, but gender. Just having the gender associated to long-term recovery is just such an interesting variable, has not ever been, or that I know of, ever been talked about. So could you give a little bit more word about that?
Yes, yes, Caroline. The differences in outcome, sex-related disparities in our cohort of patients in outcome, above all in mortality. As you see, the male gender, that is the female gender, is associated to higher risk for mortality in our cohort of patients. I don't know why, but I can figure out that we have usually we have the differences in care pathway or in the level of familial social caregiving between the two sexes, with the family support care being more feasible for male than for female patients with the severe acquired brain injury. but I think that further investigation on large cohort of patients with prolonged disorder of consciousness needed for investigating potential sex-related factors, such as the influence of sex hormones, but also the differences in pharmacological responses to pharmacological treatments that have been found as different in the male and in female. I hope with the help of IBIA DOCSIG, we can perform another project, longitudinal project, aimed at investigating these differences, sex-related differences. As you know, it's important to have a personalized medicine. When we talk about personalized medicine, we should we researcher and clinician, we should consider the differences that we have, which we have between the two sexes.
Exactly. Were these patients that you say that there is a different support system, are they actually most of the time at home? At that time, I suppose, because it's a year.
Yes, not. We didn't investigate this important factor. Yes, the place that the place where the patients were in the follow-up, in the long-term follow-up, 24 months post-injury. But yes, your suggestion is important. It's important to investigate also the influence of place where patients are. In my opinion, in my experience, the mortality of patients at home is lower than patients admitted in chronic facilities. This is my opinion, but I think also your opinion, or I don't know, I'm sure this is the same opinion by Rita too. In Italy is that.
Thank you so much for your answer. And finally, just a few questions for Aurore. Thank you very much, Anna. Aurore, I think there was some question about, did you actually record EEG also in the last study that you did, and did you see any change? And did you also look at the change in medication and how it influenced your results?
Yeah. Thanks for the question. So indeed, we also collected EEG in this randomized control trial. However, this was not our primary outcome. So I would say the majority of the patients did not have the EEG pre and post treatments, but in a follow-up paper, we will analyze the data from those clinical EEG that were recorded. So I cannot answer this question yet, but hopefully we will we can present some results in the next months or years. Even though, as I just said, not all patients received an EEG. So that's to answer the first question. And then regarding the medication, so actually the patients had to drop out if the central acting medication changed during the study, the period of the study, during the protocol. So we had to exclude a few patients because the medications changed, and normally the medication remained quite stable, and we follow that during the duration of the protocol, that the central acting medication at least would remain stable through the study.
Regarding this, the very early finding that you showed about motor cortex, was the population, please remind me, was mainly chronic patients?
Right.
Do you feel that that could be also a question of timelines that would explain these results? that at that time this patient maybe have developed spasticity that much that it's hard to see any maybe improvement or substantial improvement in this patient? And could it be also the number of sessions that are only 5 in this early work might be needed more?
Yeah, I think that would be wrong to convey the message that stimulating the motor cortex does not work in DOC patients at all. As you just said perfectly, the fact that the patients were indeed enrolled for these 2 trials at a very chronic stage, they suffer from severe spasticity, a lot of contraction also. I mean, their joints were completely fixed for a lot of patients. And thus, I mean, even though there is an improvement in the ability to move because of those motor disorders such as spasticity, retraction, and fixation, I mean, TDCS won't do much because we have those motor disturbances. But I fully think that I'm convinced that applying TDCS in an earlier stage in the ICU, when the spasticity is not developed that much, and when there is no retraction yet or no fixation yet, that might help. And of course, applying more than 1 stimulation might also be needed as for any kind of protocol with using TDCS. So yeah, fully agree with what you just said.
Well, thank you very much. Thank you very much, everyone. That was an extremely informative webinar. Probably attendants will, including me, think over what we just heard, giving new thought about new signs of diagnosis that we can consider for detecting signs of consciousness, thinking about maybe new variables that we should consider when we're looking at prognosis, and just confirming that this patient might actually have a delayed recovery, as it was shown by the TBI model system and Flora Hammond a few years ago. And finally, of course, thank you for the wonderful work that is done for treatment, and maybe that will open more idea and more option for pharmacological, for behavioral, but also for neuromodulation world that is in full expansion right now. And of course, thank you, Rita, for this wonderful presentation on pain, which is a topic of my heart and definitely needs to be more addressed in the future and more understood, because it's not very understood right now, particularly for chronic pain. But that's another topic that we know we have discussed before. We'll discuss again in the future. Again, thank you, everyone. Thank you for being there, and the recording will be available. I don't know if Roberto, you want just to say one word, because it's almost, I mean, it's already time to finish, but if not, I wish you everyone a great day, night, according to the place where you are. I'm starting my day, I know some are finishing, so I was very happy to be in this session. Thank you so much for this first webinar series. We'll have much more in the future. We'll keep you in the loop.
See you all in Dublin.
Yes,
bye-bye.
in Dublin. That's such a good, yeah, exactly.
Bye.